One of the most common sentences I hear in clinic is this: "Doctor, the pain is unbearable. I need surgery." That sentence is easy to understand. Pain is frightening. Pain is exhausting. Pain affects sleep, work, relationships. Sometimes even how a person sees themselves. So let me be clear from the start. Pain is real. We don't question it. We don't minimize it. But pain alone is not enough to decide on surgery. And understanding why can help patients make safer decisions. Pain is always real, but pain is also subjective. Two patients can have the same diagnosis, the same imaging, and experience completely different levels of pain. Pain is shaped by more than tissue damage. It's influenced by the nervous system, by previous injuries, by stress, by sleep, by fear, and by expectations. Surgery is different. Surgery is not subjective. It is objective, invasive, and irreversible. That difference matters. This brings us to something patients rarely hear explained properly, because imaging is not reality itself. Imaging is a shadow of reality. An MRI or a CT scan never shows everything. Even with normal imaging, something can still be wrong. Pain can exist without visible structural damage, and that pain is still real. But surgery requires something else. Surgery requires a clear map. We need to know what we are fixing, and why fixing it is likely to make things better. When that clarity is missing, surgery doesn't just risk not helping. It realistically risks making the pain worse. That's why in surgery, uncertainty is not neutral. It has consequences. Now let me be very clear. We do operate on pain. Pain is a legitimate reason to consider surgery, but only when we believe surgery has a reasonable chance of improving it. That belief is not based on intensity alone. It's based on whether the pain makes clinical sense, whether it matches a structural or functional problem, whether it follows a recognizable pattern, whether non-surgical treatment has already failed, and whether surgery can realistically address the cause. When those things line up, pain becomes a strong reason to operate. When they don't, surgery risks missing the target, or even worsening the pain. One of the most difficult questions I hear in clinic is, can surgery fix my pain? It is an understandable question. When pain dominates daily life, relief becomes the priority. But in surgery, the more important question is different. Do we understand the cause of this pain well enough to know surgery is likely to help? If that understanding is missing, surgery risks targeting the wrong problem or creating a new one. The question isn't how much pain someone is in. It's whether surgery is the right tool for that pain. So what does a good surgical decision actually look like? It's one where pain is real and taken seriously, where symptoms make clinical sense, where findings support a surgically treatable cause, and where surgery has a reasonable chance of improving function and pain. When those pieces come together, surgery can be life-changing. When they don't, restraint is not inaction. It is a deliberate decision to avoid harm. Sometimes the best surgical decision is not to operate. What I am talking about here are general principles, not individual medical advice.